Thank you, Sam, and thank you for the invitation to Elijah and Sanjay. I'm as disappointed as you are that John Cam is not doing this talk. I feel a little bit like this guy. Most of you will not recognise him. His name is Fabio Borini. He's currently a striker for Liverpool Football Club, which did quite well last season with this guy. And I feel a bit the equivalent of Borini replacing John Cam, although I do have to put a disclaimer in there. Now, in 20 minutes to cover the prediction and prevention of sudden cardiac death is a little challenging, so you'll forgive me if I don't cover every aspect which you may be interested in, but I've tried to pick a few which I thought were interesting to highlight some of the areas where I think perhaps we could move on a little bit in the scientific community. We know already how common this condition is, and we know as well that a number of people affected by this condition are relatively young and fit. So this is not a condition that's exclusively of old people by any means. A number of people are in their productive years of their life, and in fact the average age is the mid-60s. So we're talking about a big population of younger people. So we've really got to target our efforts to do better and save lives. I'm interested in this professionally, but also personally. This is my family tree, and this is me. And this is a little bit of a story about my family. We have a number of people in the family who have had sudden cardiac death. Now, there are many different reasons for that. Some of it we can probably explain with lifestyle. Some of it we recognise very well. And I think perhaps this group here is what we all spend a lot of energy as cardiologists trying to understand how we can do better. You've seen this diagram already, and it's the Meyerberg diagram from a paper many years ago in 1993, showing in fact that, of course, if we're going to target prediction and prevention of sudden cardiac death, really, of course, we should target this big bar here, because this is where most of the sudden cardiac death is that I've talked about already. But overall, of course, this is the overall incidence in adult population. It's a very small incidence. And on that basis, it's very difficult for us to target that group of people. We know, of course, that within cardiology, we focus on the bottom end of this curve, but we're only focusing on a small number, numerically, of sudden cardiac deaths. Perhaps we should be looking a little higher in the curve to pick out the big numbers. Population strategies. My grandfather, who died at the age of 55, who was a smoker at the time, these are big things that make a difference. And perhaps in Liverpool, if we targeted the overall population strategies, we would have a lower incidence of sudden cardiac death. And it's quite remarkable that nobody in this picture is in fact smoking at this time. When I was thinking about that, I thought perhaps maybe in Liverpool we are harder off than in London. Maybe we have more cardiac arrest because we have more social deprivation, and when we have more social deprivation, we have more cardiovascular disease, and perhaps we have people dying younger from sudden cardiac arrest. And I looked into the literature to try to understand this a little bit better. And this is taken from a Canadian paper where they're looking at the incidence of sudden cardiac death, and I have focused on under 65-year-olds here from a number of areas within the USA, which are the blue ones, and within Canada, which are the red ones. And you can see that there is a little bit of a trend in Canada, but more obviously within the US, for a higher risk of sudden cardiac death in lower socioeconomic groups. Now, I think that we can probably explain some of that on the basis of the way people have to pay for health care in the US. So when you have to pay for health care if you're not insured when you're under the age of 65. So of course, if you have less money, you're less likely to access health care, and we can understand on that basis. Interestingly, in the UK, it's not nearly as obvious. So within our state-provided healthcare system, we don't in fact have a big difference in lower socioeconomic groups compared to higher. I'm sorry I haven't got the scales on there, but the two lines overlap, so it doesn't really matter which one you are. So perhaps a nationalised health service is a good thing, I think, in terms of people being able to access care and prevent sudden cardiac death. What about the prediction and prevention? Where are we? Well, as per my family, we have, I think, three groups of patients. We have the population basis, and we have the general factors for atherosclerosis, especially smoking. Perhaps we have some genetic factors. I'm not going to focus on those because we've got many much more qualified speakers, including the next speaker, on this factor. We've got established cardiac patients, and we already use ejection fraction. That's our main thing. We look at the heart function to understand what the risk is. Fortunately, we've got away from invasive EP testing because although I think it has some value occasionally, it's far too much of a hurdle in access. Non-invasive testing is interesting, MRI, and the use of ICDs. So, where are we in the general population? We know that the majority of sudden cardiac death occurs in the community, and we know that despite everything we're doing, survival rates are still pretty poor, 5 or 10%. We know as well that most people who have sudden cardiac arrest and sudden cardiac death, they don't have a prior cardiac history. More than half of men, more than 2/3 of women. And this is data from the Oregon Sudden Unexpected Death Study. We know as well that less than a third, if we are to look at them, have what we might define as modern ICD criteria, an ejection fraction less than 35%. And we know, of course, that even when we do put ICDs into this group of patients, the shock rate conservatively is 5%, you might say up to 10% per year. So most patients, even in this group, don't have VF every year. If we're going to apply a test to the population, it has to be easy to do. Even a blood test may be too much. Probably an ECG is too much. It's even outside of guidelines for athletes in America, as you see. Genetic conditions, well, we're looking a little bit more at those, and genome-wide association studies are going on. And we know that there is some relationship in families, and it's a little disconcerting to know about my family history when I understand that if I get chest pain, I think I should get myself to a defibrillator pretty quickly. What about MRI scanning? Well, we know that if you look at MRI scans of patients, and this is a section from a post-mortem sample, you can see fibrosis as outlined by these white arrows round this heart. And you can see the same MRI, and this is in fact the same patient before the patient died. You can see that late gadolinium enhancement is there, and you can see the histology representing fibrosis. We can pick out fibrosis in MRI scanning, and in patients with dilated cardiomyopathy, it gives us a little bit more of a feel that these patients are at higher risk. So if you compare the survival curves over what is a couple of years between patients with late gadolinium enhancement in blue compared to those who don't have it in red, you can see that patients in red tend to do pretty well. Patients with late GAD, they do worse, but still not universally worse. But it might be a reasonable criteria by which to judge ICD implantation in this group, aside from ejection fraction alone. I like ECGs personally because I'm an electrophysiologist. I'm biased towards them. I don't understand MRI scanning as well. So I like to understand if I can look at an ECG and have a feel from a patient if they have a risk of sudden cardiac death. Now, when we see these notched QRSs here, fractionation in the QRSs, this is a patient with dilated cardiomyopathy here, the 6 limb leads, this is a patient with ischemic heart disease. When we see these patterns, people have looked at the outcomes, but it's a little tricky because they're looking at the outcomes in patients with ICDs. And they're picking their own events, so they're picking anti-tachycardia pacing and shock therapy from the ICD, and they're finding that these patients who have fractionated QRSs have a higher risk of these issues than patients who do not. But it's not making a mortality difference, but perhaps that's not surprising because the patients are protected by an ICD. Like all of you, I like to understand things that I can see. So I can see that this patient with long QT who has macroscopic T-wave alternans and alternating negative T-wave to positive T-wave to negative to positive is at high risk of sudden cardiac arrest, and I know that I need to worry about that patient. The equivalent, which is more difficult to see, is something called microvolt T-wave alternans. But even on this rather more subtle diagram, you can see what we're talking about, differences repeating in T-waves that make a difference to how you look at the T-wave. And if you look at patients who carry this kind of factor, you can help to predict sudden cardiac arrest. Again, it's one of those non-invasive testing things like Holter monitoring, like testing autonomic function that we can look at, but it's not giving us all the answers. It's giving us some answers. It tells us that in patients with ejection fractions less than 35%, those with both positive and indeterminate results have a higher risk than those with a negative T-wave alternans testing result. So it might have some role in deciding who may not have an ICD in that position if you were courageous enough to do that. But perhaps more interestingly, those with an ejection fraction greater than 35%, it gives us a flavour with those with a positive T-wave alternans that they have a higher risk. Again, the authors are looking at endpoints they want to look at. They're looking at the endpoint being sudden cardiac death rather than total mortality. They're looking mainly at pre-ICD patients, and this T-wave alternans has not been as useful in the ICD population. It's also not necessarily an easy test to apply because even in these are focused centres, the indeterminate result comes in a proportion of patients, and outside of high volume centres, this can be as high as 40%. All of us in this room are familiar with the role of the ICD in preventing sudden cardiac death. And I like this study because I was in my last year of training in Canada with Andrew Cran in 2002, and when this was published, I thought there'll definitely be a job for me back home when I get back, because we saw that the defibrillator in the Made It 2 study, which was judging patients on ejection fraction with ischemic heart disease, we saw that the defibrillator really changed lives, saved lives, and we saw that it really didn't matter who you picked, younger patients, older patients, males, females, very bad hearts, not so bad hearts, patients who could exercise well, patients who couldn't, no matter what the QRS was, overall, there's no doubt that defibrillators save lives. Maybe we should be using defibrillators more liberally. Or maybe we, in fact, have already reached, to an extent, a limit of where the defibrillator is useful. If you look at the Made It 2 data, and it's not all the patients in the study, I recognise that, some are taken out, and I'll explain about that in a minute, but if you look at these factors, patients who have more exercise limitation, have atrial fibrillation, are older, have impaired renal function as defined by a urea, which I had to convert from the American units, so I think it's 9.3, and a wide QRS. If you don't have any of those factors, I admit it's not a huge number, but it's a few hundred patients. There is no difference in mortality between the defibrillator and conventional treatment. But if you take more than one of these factors, that is where you're seeing your big difference in mortality. So maybe we're already at the point where we're as refined as we can be in terms of defibrillator treatment. And in fact, if we look at 1, 2, and 3 factors, you can see that with no factors, there's no difference, but these are the groups of patients where you have the real benefit. VHR at the end here is very high risk, and these are the patients with severe renal dysfunction that were excluded from the analysis that I put above. And those of you, if you're thinking about defibrillators in patients with severe renal dysfunction and bad hearts, the outcomes aren't great in either group. And if you look at this data and analyze it, you create this kind of curve. And you can see that, in fact, the vast majority of the benefit is with the patients here. You can have too low a risk and perhaps too high a risk. So the defibrillator may not be the answer. Putting defibrillators in more patients may not be the answer to preventing more sudden cardiac deaths. Although I'm going to give you the definite caveat to that, which is that this is 2-year data. It's really short term. And most of us who are implanting defibrillators are thinking about lives over 6, 8, 10 years. So where are we now? What about other strategies? We've got to remember that primary prevention ICD studies, it shows a good benefit, number to need to treat 13. But let's not forget medications for heart failure. They're all there. We've got to use these as well. Don't forget the simple things that we can reach for easily with our prescribing pads. It makes a big difference in intermediate follow-up. But remember as well, the ICD is incremental, and ICD studies were performed when patients were mainly taking ACE inhibitors and beta blockers, so big advantages for the ICD in addition to medication. We've got to touch a little bit on out-of-hospital cardiac arrest in terms of the prediction and prevention of of sudden death. And the AED, as mentioned already by Sanjay, is our friend here. And we've got to try and understand how to use the AED better, I think, because those of you who work in hospital practice and put defibrillators into patients in secondary prevention like I do, the best survivors are those that get the AED to them early. We know that. We don't really need scientific trials to show us that way. We've just got to understand how to be better. People are looking at strategies, and in fact in Circulation only a couple of weeks ago there was an edition with 3 separate papers and 2 editorials looking at the use of AEDs in out-of-hospital cardiac arrest. Please look at it, it's very interesting to read. It shows how difficult, though, even using an AED is. In Copenhagen, they really have a very good understanding about what they're doing because they're mapping cardiac arrests, they're mapping AED locations, and even then they still can't make the whole service join up well enough in that 1 in 7 only are having defibrillation before emergency services arrive. In the UK, we have the AED locator and ambulance services are aware where AEDs are in some locations, and in Holland they've published some excellent evidence showing that having AEDs is improving survival from cardiac arrest. I think we all understand that. It's important that we learn to use them better, though. That's a key thing. But the majority of cardiac arrests occur in the home, and if they occur in the home, how are we going to get AEDs to people? Because these are more likely to be unwitnessed and thereby more difficult to save. Maybe technology will help us. I was reading about the Microsoft Band. Not only does it tell you where you are, but it tells you what your heart rate is. Now, perhaps if one of these was linked to a smartphone that told you you had VF and sent a text message to someone in your street, and there was an AED on the lamppost by your house, then they could get in there and save your life. But these are the kind of things we've got to think of if we're going to save more lives. As a final aside, at least if I'm feeling bad and I go to work, my life is likely to be saved because I'm going to arrest somewhere with an AED. But if I'm a police officer, then I'm in a bit more trouble. And I was interested to see this paper in the British Medical Journal just a couple of weeks ago, looking at the incidence of sudden cardiac arrest at work for police officers and what they were doing. And I was particularly interested to see the demographics of where police officers have cardiac arrests and what they're doing, because certainly when you're in pursuit, at my age, it's getting a bit risky. I think you begin to give up clearly as you get a little bit older. But stressful events are extremely important as well, and I think this goes back to athletes and stress as well. But even within the normal population, if you can call police officers a normal population, there are risks. So what do the trials say? Well, it's a massive challenge, and prediction is very hard on a population basis. If we reduce atherosclerosis, we will reduce sudden cardiac arrest. We know that. That's the right thing to do. If we have more AEDs better placed, even within 100 meters, my goodness, that's a lot of AEDs, maybe technology will help us. With established cardiac patients, it's still a challenge. It's still a challenge. And when my uncle arrested and died a couple of years ago, despite me knowing he had a pacemaker and he had AF and had these issues, I was disappointed that we had little in the way of tools to predict that better. ICDs, will we ever have longer term studies of lower risk patients? I doubt it. So we're going to have to try to understand better who to use the ICD in. But perhaps what maybe we need is a game changer. Thank you for your attention.